And good morning to our students at American University or online now. Many of them are. So I'm going to present to you a paper on the most recent bioethics controversy in the United Kingdom, the Gard case in the UK. Now, the Gard case became a world issue in bioethics, medical bioethics, because of the many things that were considered by some as unethical, others as legal, others as permissible. So today I'll present to you the case and what possible, as in bioethics we give opinions. We don't resolve the issue, we give opinions, and the opinions will be taken by medical societies or scientific communities. So we try to revisit now parental right and medical paternalism. Basically, this is the issue surrounding the case. So what is the Gard case? I believe many of you heard of the Gard case in the UK. It's been on CNN and BBC. It's been in politics in US Congress, in UK Parliament, etc., etc. And it reached every corner of the world. And it caused some disturbances in medical bioethics around the world. So Gard, that's Gard. Now, Gard is a patient at Great Ormond Hospital, Street Hospital in the UK, the most advanced and the most famous children's hospital in London. Okay, he was born on August 4, 2016. He died July 28, 2017, barely, not even reaching a year old. 11 months and 24 days. He was brought to the Great Ormond Street Hospital ICU on October 2016. Now the condition of Gard is extremely rare. Why? Well, his condition is called MDDS in short. He had an inherited mitochondrial disease called infantile onset encephalomyopathic mitochondrial DNA depletion syndrome. Big word. In short, it's MDDS. What is this all about? Well, he had two mutated versions of the gene coding for the RRM2B protein. What is it? I wanted to show you the DNA structure and which part of the gene is affected in the particular treatment, but I removed the slide. The gene for RR2MB is in the cell nucleus. The protein it codes is necessary for generating nucleosides that are used for DNA in mitochondria, to make DNA in mitochondria, and for normal DNA repair, also for mitochondrial DNA synthesis in non-proliferating cells, and especially in cell division. So if this is a particular part of the cell is affected, if the mitochondria fail in people lacking a functional version of this protein, the effects are brain damage, muscle weakness, and organ failure, multiple organ failure, and usually causes death to children during infancy. You won't really get that far in your lifespan. So, what happened to Charlie? Charlie had congenital deafness and a severe epilepsy disorder. So he had bouts of epilepsy every now and then. He had brain, muscle, lung, heart, liver, and kidney failure at a very young age. A severe progressive muscle weakness and cannot breathe unaided, so he was on ventilator. Eyelids cannot stay open and his eyes point in different directions uncontrollably. Retina struggles to develop. So his brainwave suggests that he cannot develop normal visual patterns. So he'll be blind for life if ever he survived the disease. So what happened? According to the Great Ormond Street Hospital and many medical doctors who were consulted around the world, there is no cure to MDDS so far, and the case is terminal, meaning you just wait for death to come. But the parents, of course, wouldn't like to surrender, wouldn't like to go. So various treatment options were explored in UK and even from France and Germany. Now there was this experimental treatment in the United States being done by Dr. Michio Hirano in the US, the nucleoside therapy. The problem with it is it was tried on children, yes, but it was never tried on a child with MDDS. So there is no data to suggest that it might be effective in MDDS. But he would like to try it, and the parents would like to try it. Great Ormond concluded, however, that the experimental treatment, which is not designed to be curative, would not improve Charlie's quality of life. So how did GOSH came to this decision about his treatment that is futile? the clinicians of GOSH, Great Ormond Street Hospital, had to balance whether this experimental treatment, which is not meant for MDDS, was in his best interest or not. So the main issue is it in the best interest of Charlie to undergo the therapy or not? Now, Charlie's brains, when he was scanned, showed that there was extensive damage at a cellular level. Dr. Hirano even agreed that the experimental treatment will not reverse the condition of Charlie Gard, and that brain damage has already occurred, and the brain damage is already extensive. The entire UK team of GOSH, including the consultants and opinions of other doctors and clinicians, and even the consultant that was assigned by the parent, chosen by the parents, agreed that further treatment would be futile. It would not bring any effective benefit to Charlie Gard. Would not be effective benefit. So the experimental treatment, many doctors in the US and even in Germany and France wanted Charlie Gard to try the treatment, at least try it. Whether the benefit would only be 20% or 10%, they should try it because it might be effective for MDTS. Dr. Michio Hirano, the chief of the Division of Nucleomuscular Disorders at Columbia University in the US, he was contacted by the consultant assigned by the parents of Charlie Gard for possible nucleoside therapy. But he, and even the doctors of Great Ormond, agreed that the experimental treatment was unlikely to keep Charlie alive if the brain damage is already irreversible, which in the case of Charlie Gard now is irreversible. Hirano said there was a theoretical possibility that the treatment would provide some benefit. Careful with the term, he said theoretical possibility, because there's no data yet to prove that it might be effective for MDTS patients, especially kids. Now, on January of 2017, the GOSH team, as per record, had the intention to attempt the nucleoside therapy. So they at first agreed that it may be effective. So they scheduled for a meeting with the ethics committee of the hospital around January of this year. And Charlie Gard, since he had difficulty breathing, he was scheduled for tracheostomy. Tracheostomy is they put a hole so that you can put the tube for you to breathe, at least normally. Okay, on January 16th. Now, Hirano was invited to examine Charlie in January this year. Unfortunately, he was only able to go to the UK in July this year. So the span of time, the months for waiting, aggravated the condition of the brain damage and other cellular damages in Charlie. So that by January 10, Charlie had epileptic seizures every day. Not only once, but even twice and thrice, as per record, which continued until January of 2027 of this year. Now, epileptic encephalopathy was detected in Charlie, meaning greater brain damage because of the epilepsy. January 13, the ethics committee meeting was postponed for some reasons. So the GOSH doctors informed the parents of Charlie that brain damage had made the experimental treatment futile. So the medical team already made the decision that the nucleoside therapy is already futile. And in light of the risk that he was suffering, they withdrew supporting the idea of nucleoside therapy. Now this is where the problem came. The parents and the medical team discussed ending life support to Charlie already because treatment is already futile. Rather than undergoing the nucleoside therapy, they recommended that Charlie be given palliative care only, okay, as he ends his life. By this time, relations between the parents and the medical team already became deteriorated. They were quarreling and shouting in media, etc., etc. So the parents disagreed with the doctors of GOSH with the recommendations, and they wanted to go to New York to try the nucleoside treatment. But Charlie is not a citizen of the United States. More than enough fund was raised by crowdsourcing on FB. Charlie was even made a citizen of the United States just to facilitate the transfer of Charlie Gard from GOSH Hospital to the US. Unfortunately, the move was prevented by the court, and Charlie was not allowed to leave. Intervention of the court was sought by the parents and by the GOSH medical team for ending life support and providing palliative care. So they went to court. So why was it brought to court? Because of the disagreement between the parents and the medical team in GOSH. On February 2017, the team of medical doctors from GOSH asked the court for an order that Charlie lacked capacity to make decision regarding his medical treatment. Of course, he cannot make the decision, he's only an infant. Second order they were seeking from the court was that artificial ventilation can be withdrawn now because treatment is already futile and palliative care must be given. That it is lawful for his treating clinicians to provide him with palliative care only, and that it is lawful and in Charlie's best interest not to undergo nucleoside therapy. The parents disagreed. They had lawyers, so they appealed to the High Court. The High Court decided in favor of GOSH that they can now withdraw treatment, ventilation, and that they should provide palliative care only instead of the nucleoside treatment because it is not for Charlie's best interests. The parents went to the Court of Appeals in the UK. The UK approved or ruled in favor of the High Court's decision. That Charlie's best interest, it would not be to Charlie's best interest to be allowed to die, and he must be allowed to die with dignity. They went to the Supreme Court of the UK to appeal the case again. But the Supreme Court upheld the decision of the High Court and the Court of Appeals. Finally, they went to the European Court of Human Rights with right to life and sanctity of life as the foundation of their case. But the European Court of Human Rights endorsed the decision of the UK Supreme Court in June 27, 2017. Now, of course, the issue became sensational. Why? The parents and the supporters of Charlie Gard went to social media and released notes and comments, etc., for everyone to see. Many of those comments are not medical based, were not scientific, blah, blah, blah. They were more emotional in argument rather than objective and scientific. And it became a sensation. They even raised more than £1 million to support Charlie Gard's treatment in the United States. And it became a world issue. There were activists supported Charlie Gard. And even politicians, the bandwagon is there, and so they have to ride the bandwagon and support the Charlie case gates. Even in the United States, even the President of the US, Donald Trump, who advocated for the transfer of Charlie Gard to the United States. Even the Holy Father made a statement supporting Charlie Gard's right to life, and that Charlie Gard must be given the chance to undergo the nucleoside therapy. Of course, the interest of science is a big issue. Is it for the interest of Charlie Gard or interest of science? Are we only interested to know whether nucleoside therapy is effective in NDDS, or we are really intent on saving the life of Charlie Gard? So those questions. Of course, religion came to the fore. Okay. Now, unfortunately, the court never agreed. So the parents accused GOSH of delaying treatment until it was already too late. Because remember, the Dr. Hirano only went to the UK July. He was contacted January. Charlie's parents wanted to move him to a private care and wanted to wait a week or so before they ended mechanical ventilation, but the court objected. So they went to the court again on July 25 and 26. But the judge already made instruction on what to do with Charlie Gard. First is that Charlie shall continue to be treated at GOSH and not move to a home care, and for the period set by the court, of course. And that Charlie shall be transferred to an agreed hospice, the details of which are set up in the court's decision. Now it is lawful now, according to the court, for artificial ventilation to be withdrawn after a period set out by the court. So the ventilation was withdrawn on July 26. On July 28, Charlie Gard died. The mechanical ventilator was withdrawn and was given morphine to relieve any pain beforehand, and died within minutes. So that ended Charlie Gard's life. 11 months, 24 hours. So, what are cases? Now, the Charlie Gard case raised several ethical issues in the field of medicine and science. Some of these are futility and best interest. When is a case futile? Who decides whether a case is already futile? Is it the court, the doctors, or the parents? Of course, it's easy to determine parents are out of the picture unless the parents are really experts, scientists, or doctors. But best interest is a difficult topic, so the court must decide. Parental right and autonomy in pediatric end-of-life ethics, it's more difficult than in adult cases. Paternalism and justice, the involvement of court in resolving bioethical or medical issues of ethics, of course. withdrawing and withholding treatment, especially to infants, hydration and nutrition. This has been settled by the Pontifical Academy for Life some years ago. They declared that hydration and nutrition are not medical interventions. They are ordinary means of sustaining life. Therefore, they should not be withdrawn. Unless otherwise, they cause the death of the patient. Okay. And of course, the right to life and sanctity of life. We will not take all of these, or else you'll end up having 3 units with me as a course in the university. I'll only take one issue. Our main concern is whether it is ethical for medical team or the court to override parental decision in futile pediatric condition. Consequent to this is what ethical grounds can be used to justify overriding parental right by medical professions and the courts. Although there are established protocols in the United Kingdom and in the US, I'm not familiar with other countries, but some issues need to be revisited and then clarify whether these conditions settled by rules of court is ethical or not. Remember, not everything that is ethical is made legal. Sometimes what is made legal is even unethical, but that's how the court works. So, who have the final say in irreconcilable disputes over the treatment of sick children, parents, doctors, or courts? Now, in the United Kingdom, in Britain, parents do not have absolute right to make decisions for their children. That's according to law. It is normal for courts in the UK to intervene even when parents and doctors disagree on the treatment of a child. I think even in the United States, I don't know in Japan, courts normally intervene in disagreement between parents and doctors or in your respective countries. In the Philippines, it doesn't happen normally because in the Philippines, medical paternalism is very much practiced. When the doctor decides, that's it. No. Okay. The rights of the child takes primacy over the rights of the parents in the United Kingdom, with the courts weighing issues such as whether a child is suffering and how much benefit a proposed treatment might produce. So, parental right is understood, at least in the UK law, as the right and responsibilities of parents, the right and responsibilities parents have in respect to their children. This includes medical care and its withdrawal in case it is already futile or it does not work for the best interest of the child. Generally, in the United Kingdom, a consent of one parent is enough for a medical treatment. Even if the husband disagrees or wife disagrees, but consent of one is enough for you to receive medical treatment if you're a child. In some countries, they must agree, both of them must agree. Parental wishes and interests are important, but not necessarily determinative. It does not determine what kind of medical treatment you should receive. They will be considered, they are important, they will be listened to, but it may not be the basis for determining what kind of medical treatment a child may receive. And that is determined by the court. Okay. Now, in my readings on issues on parental right and medical decisions, how to override, when it can be overridden, what ethical grounds can be used to accept overriding parental rights over the decision of a medical team or court, I was able to identify 7. Many of these are already enshrined in the laws of the European Court and the European United Kingdom and in the US. And many literature identified, proposed some protocols in relation to this, and I tried to summarize them in 7 ethical principles. Of course, the most basic would be harm principle. The most basic of our principles, do good and avoid evil. Thou shalt not harm, always do what is good. Unfortunately, the problem with the principle of goodness is we don't have a standard for goodness. Goodness is normally a subjective value, character, normally, depending on culture, upbringing, religious background, etc., etc. So when you say do good, what good would you like that person to do? Now, who determines what is good? In the UK and in Europe, a good for a patient may be determined by the court, but it's always legal and scientific as a basis. Harm principle. What does harm? What's the relationship of harm principle to our case? The harm principle says if further treatment causes more harm than benefit, overriding parental decision is reasonably justified, but you have to fulfill some conditions. I was able to look for these conditions in different literatures. 1, if the insistence of the parent puts the child at significant risks of serious harm, if it will aggravate the condition rather than treat the condition, then the parental decision must be overridden by the medical team or even by the court. Second condition is if the harm is imminent and it cannot be prevented by the requested intervention. If it is already futile, if the harm is imminent, meaning it cannot be prevented, it can occur 100%, it can be overridden. The parental decision can be overridden. If the requested intervention is not proven to be efficacious, if it is not proven to be effective. Now the issue in the court was how effective is effective? Is 10% effective? Is 5% effective? Is a theoretical possibility effective, meaning effectiveness of the therapy? So I was reading the court decision, it's quite long. When I have a copy, I have the PDF file in my computer. You have to read it and you see the debates inside the court, how doctors and lawyers debated on the issue, and you see the different perspectives. So if it is not efficacious and the parents would like to have it, the medical team or the court can override the parent's decision. Another one is the projected burden to benefit ratio of the intervention requested is significantly more harmful than medical recommendation. On that, the state, meaning the court, would intervene in all other similar situations regardless of the nature of the parent's reasons. So the medical team can always run to the court if the parents disagree. The second principle is the best interest principle. Many protocols in this matter suggest that you must always act on the best interest of the patient. Now, acting in an individual's best interest is acting so as to promote the maximum good of the individual, promote the patient. Now, it does not say to promote perfect wellness or perfect treatment, but it says maximally the good of the individual. Now, no matter how maximum that good is, it will be determined by the medical team or the court. Now, the best interest principle is to serve only as a regulative ideal according to many literature, not as a strict and literal requirement, and that a mere failure on the part of the parents to optimize the child's interest is not sufficient to trigger state intervention or court intervention. Now, parents' failure to choose the treatment option that is in the child's best interest is not the appropriate threshold for external intervention. Rather, this role is taken by the principle of harm or unreasonable option. So, best interests are used to guide the court about the appropriate treatment to require according to Copeland. Now, the best interest standard is meant for fair balance between many people's needs, rights, and interests. So when, according to many literature, when you use the best interest argument, you are not supposed to be only thinking of the best interest of the child, but also the best interest of the parents, society at large, even the best interest of the medical etc., etc. So there are many other things you need to consider. Most of the time, we already consider the interest of the patient. Okay. Now, constrained parental autonomy. What do I mean by this? Ross argues that parents are not supposed to be interfered with when it comes to deciding. You must only interfere when they fail to provide for their child's basic needs. One of these is reasonable treatment. We have to qualify treatment. They say it must be a reasonable treatment. Now, whether the treatment is reasonable, that is not for the parents to decide according to many literature. There are conditions to be met. Like medical experts have agreed that treatment is non-experimental, it is appropriate, that denial would result to deprivation of life, that anticipated result of the treatment actually benefits the patient. Okay? And that is connected to this principle, the medically reasonable alternative. Nucleoside therapy is an alternative, but is it medically reasonable? And the court decided it's not, so it must be denied. The parents' decision must be overridden. Of course, the responsible mode of thinking of the parents are the parents judged to be responsible in their decisions when it comes to treatment. That's a difficult matter to determine, but I don't know how they do it in courts. I don't know how they do it. So a mode of thinking is sufficiently responsible unless the parent decisions seem, from most perspectives, as shockingly reckless or negligent. Of course, parents will not accept that you are a negligent and irresponsible parent deciding to treat your child this way. No? Okay, so the rational parent principle standard does not require parents to decide in line with the child's best interest and enables parents to make treatment choices that increases risk of harm. The limit relates to inevitable harm. Parents should not be permitted to choose so low a level of care that it only increases risk of harm. So the leukocyte treatment offers low level of care. And of course, the last one is the balance of cost and benefits. When you balance the cost of benefits according to many bioethicists, you have to consider not only the cost of treatment to the patient, but also the benefit of treatment to the patient and the cost borne by others as a result of patient's treatment. We have to accept the fact that in many countries, treatment depends on money. If you have the money, you can be treated. If you cannot afford it, you have to die. I'm sorry. The end of life is coming. Many cases like that in the Philippines when healthcare system is not really that as effective as other countries. So the best interest of the patient can be overridden if marginal costs are greater than marginal treatment benefits when the cost of third parties are considered. As a final word, in my involvement with bioethics years now, I only have two basic principles I recommend usually to my students in hospital admin or in nursing management or healthcare management. Right to life and sanctity of life does not mean pursuing life even if life is no longer a good to be pursued. When nature has decided that life has to be ended. There are two Latin principles that we normally use, even in court. Lice corrigere defectus naturae. In English, it means defects of nature can be corrected. Defects of nature can be corrected. To assist nature in the remedy and restoration of its proper functioning is in accordance even with common sense. It means to say that it is ethical and legal to employ scientific and medical methods to uphold right and sanctity of life. But there is an equivalent principle. There is a partner to this principle in Latin. Ad impossibile nemo tenetur. Meaning in English, no one is obliged to the impossible. No one is obliged to the impossible. To employ that which runs counter to nature, or even to what has already been decided to be so, and use it to substitute its irreparable defects does not per se solve the problem. So if it is deemed impossible, no one is obliged to have it. I think that's even our principle when it comes to withholding treatment, optional and ordinary and extraordinary means of treatment. I think. Thank you.
Thank you so much for your excellent case studies. Every time I learn so much from your presentation, but I'm not the specialist of the bioethics, so I can make some extensional discussion about your case study. But what I wonder is, what is the best way to make a decision criteria when such a dilemma makes conflict? So I think it is very different according to the ethnic groups or the social situation, social cultural context, or even the education level of the parents. The parents, if you have many details of the medical knowledge, they can interfere to the decisions of the medical doctors. If they have little knowledge of the special, the medical treatment, they are easily excluded from the discussion. So it's very difficult to make the decision and the criteria in the society. Do you gather such data about the dilemmas and to make the universal or very effective rule how to make a decision?
If you look at the manuals, the three biggest medical associations, the WMA, the World Medical Association, the BMA for the British, and the AMA for the American, one of the things they normally recommend in cases like this, really, and I think this should be instituted in all, not only tertiary hospitals, but even in clinics, is family session or family dialogue. But you have to, one of the things that that's there is, you have to be very careful with who influences the parents. So it is necessary that the medical team should meet with the parents in a conference, and they should explain all alternatives. This is part of the autonomy consent requirement. Alternative, what are the risks and the possible benefits? They should include also, alternative may even mean traditional medicine. If it is, actually in some hospitals they have a department ready for traditional medicine. That you can have treatment in traditional way. What do they recommend is a family session, a conference, a family conference. And doctors are supposed to be trained how to facilitate family conferences. In a family conference, they normally require a psychologist to be there, depending on who the patient is. If it is a child, they need the parent, an advocate for the patient. If a lawyer is needed, but the lawyer will be the least one to be called, because normally they decide based on what is written in the law. Not everything the law can respond to. If there is a disagreement, that's when they call lawyers and court. But in practice, what's happening is they immediately run to the court without family conferences. Without family conferences. But in terms of principle to use in resolving the issue, I think the established principles that we have, especially the ones that are identified by IBC, by UNESCO, can be used, like the demands of justice. Example is when all possible treatments are requested by the patient, but to the detriment of the other members of the family. Like, it is too costly, you have to sell all your properties to have the treatment. Or you have to ask your siblings to stop studying in order for you to finance the treatment of the child. The principle of justice will say the treatment is not meant for the child. The greater good may be compromised for the good of the one. So I think the established principles of distributing justice, you have to be careful with justice, you have to qualify what justice you are seeking in resolving the issue. The justice, autonomy, consent, blah, blah. I think they are all effective. But again, not all parents know these things. So you have really to engage them in a family conference. But when it comes to a single protocol that can be applied universally, they don't recommend it. It must be resolved according to national standards, according to cultural standards, I believe so. So I think the ABA, the Asian Bariatrics Association may recommend, may propose a protocol. I think it's necessary for ABA to make things like this so that we can make our presence felt in the world. Or probably give opinions on the case, publish it. It will be a part of the discussion of medical associations or bariatrics associations worldwide. But even IBC does not recommend him. The precautionary principle is one. Look before you jump. Look closely before you jump. So when you cannot predict the possible effect, you have to suspend the possible actions.
Okay, one more.
Yes.
Short question. In Korea, nowadays, some doctors, medical doctors, refer to the artificial intelligence problem before this decision. In the case of the referring to the artificial intelligence, it seems to be very useful, but the moral responsibility goes to whom?
Yes, that's correct. If you remember, Professor, last year, I talk about quantified self. When data is quantified, It becomes a number, and based on the number, we make medical decisions. But even if you not asking a doctor to diagnose you, I think that's what happened also with the Charlie Gard case. They saw it in the net that there is this nucleoside therapy that may be possible, and they banked on it. They already made a decision, even without consulting the medical team of GOSH, that he should undergo the nucleoside therapy. But of course, the medical team disagreed with the parents. So really have to be responsible. The case may be similar, but the particularities of the case may be different. So one recommended treatment may not be effective to you, no matter how effective to others. At least they should be. I think it's the work of the medical society to educate really our people. Not everything that is possible is permissible. Not everything that is possible is permissible.
Thank you so much.
You're welcome, Professor.
Actually, there are a lot of questions and answers in your presentation, but I have very simple questions here. Is it a case of euthanasia?
Was it euthanasia? Was the intention to end life, or the intention was to allow nature to decide its course? Well, at least in the judgment of the High Court, if you read the decision, it was not a euthanasia. The withdrawal of treatment and the suspension of the ventilator was meant to allow, and when the patient is dying, so they even have morphine so that he will not feel pain. It was not a case of, they believe it was not a case of euthanasia. But for the other side of the story, like the Vatican and those who advocated for the right to life, it was an active euthanasia. The intention was to end life. But it was not the way the court and the GOSH saw the case. It was rather accepting futility. That the treatment is futile. We cannot do anything anymore. That continual application of ventilator and life-sustaining device will only prolong the suffering and the pain of the child. So they were ending the pain and the suffering, but they were not ending the life. That was their argument. But if you take the argument of sanctity and right to life, they will say it's an active euthanasia because they actively did something that finally ended the life, like removal of the ventilator, removal of life-sustaining devices. It was not passive euthanasia when you do not do anything, just allow it to die. They were removing what has already been connected. So it is active for those who advocate.
Okay, if we don't consider this issue as an euthanasia, then other questions are involved with this problem. For example, there may be from Christian community, and sometimes when the doctors take decisions, they must follow the values or religious rituals. Is it okay?
Sorry?
The doctor, when doctor takes any decisions about the patient, they should follow the principles of prevailing values of the society.
What has been recommended by the scientific and medical community? Yes, they follow the procedure and the protocol.
Okay. So, for example, in Christian society or Christian belief, there is a very great idea. The children are not the possessions of the parents. It's very common.
Yeah, it's a gift. Yes.
So in that case, what would be happened about the right parents' right?
It was. I think the court's decision, I think, is valid. No?
Yeah.
It is not an absolute right. It is not an absolute right. One of the things related to that would be in relation to children as a gift, in relation even to artificial and reproductive technologies. A document from the church will say, a child is not a right, it is a gift. If it's not given to you, don't demand it and undergo artificial insemination, or etc. etc. The bioethical things in the church are quite different with secular bioethics. So it is not absolute as a right. Now, I think you may be going through the idea of, will it not be in Christian perspective, will it not be, again, it related to euthanasia or actively ending, life? I think even the Vatican instruction on euthanasia and withdrawal and withholding treatment, the withdrawal or withholding of life-sustaining device is ethical, except the withdrawal of food and hydration. Unless otherwise, food and hydration causes the death directly of the patient. So even the withdrawal of ventilator is allowed when it is already futile, meaning it's not beneficial to the patient. It creates more burden than benefit. There are 4 criteria I think they identify. So if you fulfill the 4, it's okay to withdraw, except for hydration and nutrition, because they are not treated as medical treatment, but normal. And that's demanded by nature. It is required, unless it chokes the patient, it causes the patient to die. So I think it will not be a violation of the right to life.
There's another problem. This is my last questions. In bioethical practices, there are many principles are working there. The trustworthy, trust between patients and doctors, trust between doctors or healthcare professions and the parents of patients or relatives of patients. But in that case, I think there is some limitations and there is some problems of trustworthy, because the patient, the doctor and the parents of these patients, they are not come to the consent, come to the same point about the treatment of this child. So how can we weigh the principles of trustworthy in that case?
Trust in the medical profession is established by, number 1, if you are ethical and if you deliver quality service, ethical quality, service quality, facility quality. So if you have those 3, social trust is there. Unfortunately, I think based on my readings, it was rather, there were those to influence the parents of Charlie Gard. If you look at the case, it's actually a simple case in hospital pediatric procedure. But there were people, interest groups, who influenced the parents of Charlie Gard, so that it became a political issue even in the UK Parliament. There are lobby groups fighting for, continuation of ventilation, blah, blah, blah. And I don't think that aggravated the case. And that added more ethical issues to the case because of involvement of third parties in the resolution of the case. It may be a failure of GOSH to really implement an effective family conference so that they could have controlled the situation. And another issue is social media is so accessible. You can post anything. You can claim anything in social media and people will believe it. That added more complexities to the case. Yes. That made it worse. Yes.
One more question. It will be the last question. Now I would like to know, because you said there must be a family conference before the doctors decide about the treatment. In India, there is what you call Consumer Protection Act.
Yes.
And Consumer Protection Council, where if they don't agree with the doctor's treatment and if there is some negative results because of the treatment, they take the doctors to the court.
Yes.
And they are punished or they are asked to give some compensation. Is there such an act? Is there such
I think they have, but that is, I'm sorry. Yes, there are. In many countries there are. Even in the US and in the Philippines, and even I think in Japan you have consumer protection. But the problem with that is, it is post-act. It comes after the act has already been done. What is family conference is, it happens before any action is supposed to be done. It's preventive ethics. You prevent something from happening. So you meet in a conference and then you talk about all the particularities of the case. With consumer protection is, that happens after. When an action has already been done to repair damage or to compensate for negligence or malpractice. So I think we advocate more preventive ethics than reactive ethics. It means we prevent, you impose ethical protocols to prevent cases from happening, such as this.
Thank you very much.
Thank you.